Welcome to the lecture on the circulatory function of the heart. I'm going to review the A and P very briefly, and then we'll talk about the heart, what our patients are going to look like in kind of a brief overview of the heart. And then in the fall, we get into more specifics and details of cardiac disease. But for now, let's just talk about the flow of blood very quickly. Deoxygenated blood comes from the body through the superior vena cava into the right atrium. Goes down in the right atrium, through the tricuspid valve, into the right ventricle. From the right ventricle, it's pushed through the pulmonary valve and out through the pulmonary artery, which is the only artery that carries deoxygenated blood. From the pulmonary artery, it goes out into the lungs and it's reoxygenated, and then the blood comes back into the left side of the heart through the pulmonary veins. The pulmonary veins are the only veins that carry oxygenated blood. From there, the blood goes into the left atrium. You can kind of see that there. And then it goes down through the mitral valve into the left ventricle. And then it goes up through the aortic valve and out to the body through the aorta. And then the cycle begins all over. So that's the basic cycle of the heart. Here's another picture that might be a little bit easier for you to see it, that talks about the vessels of the heart individually and what they do and how they function. Another good picture here. And if I were you, I would draw your own picture of the heart and trace the steps of how the blood flows and make it your own picture. When I do a diagram of the heart, I just use a box, and it makes it very easy for me to see how the flow works. On this slide, you can see what I just already shared with you, where it begins, how it enters the right atrium, goes through the tricuspid valve, and then on and on. And I'm not going to go through all of these steps for you because you can certainly read them yourselves from the PowerPoint. But just remember that the pulmonary artery is the only artery that carries deoxygenated blood, and the pulmonary vein is the only vein that carries oxygenated blood. You kind of want to know the valves and what they do, and the biggest thing you want to know about the valves is if they're not intact, how they work. The most important part of the heart is the left ventricle, and with systolic contraction, the left ventricle generates enough pressure, it closes the mitral valves, opens the aortic valve, and pushes the blood out into the body. People who have congestive heart failure, any of those issues, it's the left ventricle that takes the hit and enlarges, and if it's not working properly, then it will swell, cause backup into the lungs, CHF like we talked about in class. Okay, so let's talk about the cardiac cycle, diastole and systole. The phases of the cardiac cycle are described in relation to how the pressure in the heart changes, especially the pressure in the volume in the left ventricle. During filling, which is diastole, that's when the heart's relaxing. So that's a balloon just laying flat ready for you to put the air into it. And then contraction is obviously when the heart contracts, and it's like you letting the air out of a balloon. Diastole makes up about 2/3 of the time of the cardiac cycle. Part of it, again, is relaxation and filling of the atria and the ventricles. And the systole is the contraction and emptying of the atria and ventricles. And then the cardiac cycle begins again. So when you're listening to the heart, the first sound you're going to hear is lub. And that's the tricuspid and the mitral valves closing. And it's the beginning of systole. So that is the beginning of the heart contracting. And then the dub sound is the aortic and the pulmonic valves closing. And that's the dub sound. Now, just so that you know, for this exam, I am not going to test you on what makes what sound when, but you do want to have a good idea of what you're listening to and why it could be a problem if you're missing a sound or there's a murmur following a sound. But again, that's more in depth than we're going to go for this lesson. This is just the basics. Here's a good or further explanation of S1 and S2. S1 is the closure of the mitral and tricuspid valves, low-pitched sound. Again, marks the beginning of ventricular asystole, just like I said on the previous slide. Now you have it in writing. And S2 is the closure of the aortic and pulmonic valves, and you can hear it best at the base of the heart. When we learn the heart sounds in clinical, you can remember, or should remember, where do you put your stethoscope to hear which sound. And again, we learned that in clinical at the beginning of the term, so you might want to review that. Now we're going to talk about the electricity of the heart and how it all happens. And if you consider your heart to be like your house, consider the SA node to be like the electrical box outside of your house. And once the electricity is hooked up to the electrical box, that would be the same as the SA node. That's where the power starts in your house. Then the next step would be the power cords that go down the wall and then under your house that basically feed the rest of the house. That's the AV nodes. So that's second in command. Then third is the bundle of His. So if you follow the electricity through your house, the power box starts, then you have the cord that's very big and thick. It goes under the house. And then under that cord, or branches of that cord, that go out to the rooms of your house. And that could be the bundle of His. And then you have the right and left bundle branches, and consider those to be the outlets where you would plug things in. And then the Purkinje fibers are the very tiny individual parts that stimulate the very tips of the heart muscle, and that would be like the outlets in your house. So if you want to draw that picture, you can see here's your electrical box. And then you go on down to your AV nodes. That's the cord running under the house. Then you're going to go even a little bit further to the bundle of His, which is right about here. And again, that's the cords that take the power out to the rooms. And then you have the left bundle branches. And those go to the individual rooms, individual outlets, and then your Purkinje fibers you see very much at the end, and those are the outlets themselves. I don't know if that helps you at all. I'm a pretty visual person, and that's how I like to remember it and draw it. So you can come up with whatever you want yourself, whatever works for you. But this slide here is a very, very good one because it tells you exactly what's going on when and where, and then you can draw it again on your own. So, cardiac output. Very, very important. This is the amount of blood ejected from the left ventricle in 1 minute. Your stroke volume is stroke volume times heart rate equals your cardiac output, and the ejection fraction measures the left ventricular efficiency. Most people are somewhere in the 60 to 65. The lowest I've seen on a living person is about a 27, and they didn't live very long. And I've never seen anyone in their healthiest state with an ejection fraction of over 70%. So if yours is not 70%, it's not a problem. Stroke volume is the amount of blood that's ejected by the ventricle in one contraction. So the average is 60 to 80 milliliters per beat. So if you think of a medicine cup is 30 mLs. So it's that times 2 to 2.5, maybe 3. This is all discovered on an echocardiogram of the heart. There's no way to test it without some sort of testing. It's not like you can take a pulse and figure the stroke volume. Average resting heart rate is about 75 beats a minute. Average resting cardiac output is 5 to 6 liters within 1 minute. So that's a lot of moving blood around. And again, the ejection fraction is measured of the ventricle efficiency. So basically when the ventricle relaxes, it fills up with blood, and then it beats. And that ejection fraction is how much gets ejected with every heartbeat. And here is an assessment of, or a way to do an assessment of the heart. And we've already done this a little bit, and you certainly read your textbook on this. But the first thing we're going to do is inspect. Are you seeing any bulges that could be aneurysms? Are you seeing like pulsating of the actual heart itself? And then when you palpate it, what are you feeling? Are there bruits? I'm sorry, are there thrills? You hear a bruit, feel a thrill. And we always want to make sure that we inspect, auscultate, palpate, and then percuss. I'm sorry that these are out of order on this slide, but always do them in the same order. Here are the landmarks, and again, you learn this in clinical, where you can hear each sound. And so when you place a stethoscope on the second intercostal space, what you're going to hear for each one. And again, you did this all in clinical, so this is just a review for you. Auscultation obviously evaluates the heart's rate, rhythm. You can hear murmurs. You can hear valve function and dysfunction. You want to make sure that you press the diaphragm close to the chest. Especially at this point, you're really just looking for lub-dub, S1 and S2. And sometimes you'll hear this S1, you'll hear lub-sh, lub-sh. And that means maybe that valve isn't working so well. Murmurs, there's a skill to learning how to read them and how to understand which one they are. And at this point, if you just call a physician and say, hey, I'm hearing something, that's probably all they need to know at this point in your education. But as you practice, the more people that you can auscultate, the more hearts you hear, the better off you'll be in your auscultation skills. Another sound is an S3 sound, which is called a gallop. And it's considered normal in patients who are young and can be an early sign of failure or ventricular septal defect. Doesn't have to be, but can be. And then S4 is an atrial gallop. And this may be heard in patients with hypertension, anemia, ventricular hypertrophy, which means that their ventricle is getting bigger and hardening. People who have an MI might have an atrial gallop, aortic or pulmonic stenosis, or even sometimes a pulmonary embolism. And again, you want to know very briefly what S3 and S4 are. I'm certainly not expecting you to hear them at this point. That again will be a practice skill that you'll develop, but you just want to know that they're there. There are different kinds of murmurs, both systolic murmurs and diastolic murmurs. Systolic murmurs usually identify aortic stenosis or mitral valve regurgitation, and those murmurs will happen between S1 and S2. So you'll hear lub, sh, dub, lub, sh, dub, or some sort of combination like that. And a diastolic murmur is notes mitral stenosis, aortic regurgitation, and this happens after dub. So it's between S2 and S1. So you'll hear lub dub shh, for that kind of a murmur. And of course, everything has a grade and a scale, and those are graded by intensity, and again, not necessary for this lecture. Now, these tests on this slide are very important for you to know. They might not pop up on this exam, but they will pop up all over your practice because so many people have heart disease. EKG, X-ray, ultrasound, TEE, echocardiogram. I would look all of these up and have a brief understanding of each one of them. Again, in your folder of meds, labs, ATI templates, all of the things on this slide will be very important for you to know and practice. So this is video 1 for the circulatory system, and video 2 will be coming up soon.